Welcome to the Deep Dive, the show that really extracts those crucial nuggets of knowledge, giving you a bit of a shortcut to being well-informed.
That's the goal.
Today, we're taking a deep dive into a topic that is absolutely fundamental for your nursing journey: obstructive pulmonary diseases.
Really key stuff.
Imagine needing to consciously think about every single breath you take, every minute, every hour,
And
every day.
hard to even picture, isn't it?
Exactly. But that's the stark reality for many living with these conditions. At their core, they all share a common problem: increased resistance to airflow, usually because of narrowing or obstruction in the airways.
Right. That's the unifying theme.
Our mission for you, the nursing student listening in, is to simplify and, well, demystify four key obstructive lung diseases: bronchiectasis, cystic fibrosis, asthma, and chronic obstructive pulmonary disease, or COPD.
We'll guide you step by step through their unique challenges.
Yeah, focusing on what you as a nurse really need to assess, prioritize, and of course, teach your patients. So let's unpack this.
Okay. What's truly critical here, as you step into practice, is recognizing that while these conditions each have, distinct origins and specific treatments, they all share that underlying thread of compromised airflow.
That commonality.
Exactly. Understanding this, alongside their unique nursing approaches, is key. We'll build a strong foundation for your studies by highlighting the pathophysiology, the hallmark clinical signs, the gold standard diagnostics, and most importantly, the high-priority nursing management strategies.
So it's not just about memorizing facts.
No, absolutely not. It's about connecting the dots for real-world patient care. How does this disease process actually look and feel for the patient, and what can you do about it?
All right. Our first stop is bronchiectasis. It might sound like a mouthful, but essentially we're talking about airways that have permanently lost their resilience.
Yeah, their elasticity, they become weak, dilated, and they really struggle to clear secretions.
And it's quite common. It affects over 500,000 Americans,
Yeah.
more commonly women, and we see it more as people age.
That's right. The hallmark of bronchiectasis is this permanent abnormal dilation of the medium-sized bronchi. Normally, these airways have elastic and muscular structures that help them stay open and, clear themselves.
Like tiny springs.
Kind of, yeah. But with bronchiectasis, chronic inflammation just destroys these structures. Imagine like an escalator that's broken and jammed.
Okay.
The mucociliary mechanism, our lungs' natural clearing system, gets damaged. This creates a really vicious cycle where thick mucus, often colonized by bacteria like Pseudomonas, just accumulates in these dilated pockets.
Leading into more infection.
Exactly. Ongoing infection and inflammation. The result: decreased expiratory airflow and a real struggle to clear secretions. In adults, the main cause is often poorly treated or, untreated lung infections.
What about kids?
In children, cystic fibrosis is the most common underlying cause. But other risk factors can play a role too, like systemic issues, maybe poorly controlled diabetes or inflammatory bowel disease.
Okay, so with that complex process happening inside the lungs, what does a nursing student actually see? What do they hear when they're assessing a patient with bronchiectasis?
Well, the most striking sign, the one that really stands out, is a persistent cough. And it's not just any cough. It's got consistent production of thick, tenacious, often purulent sputum. Sometimes it can even be blood-streaked.
Okay, that sounds pretty distinct. And listening to the lungs.
You'll likely hear adventitious sounds, specifically crackles and maybe some wheezes. Beyond that, patients might complain of dyspnea, maybe some weight loss, and you might see clubbing of the fingers in more advanced disease.
And there's a safety alert here, right? About hemoptysis.
Absolutely critical. The development of new, fragile blood vessels in those damaged airways can lead to hemoptysis, which is coughing up blood. And massive hemoptysis is a true life-threatening emergency requiring immediate intervention.
Got it. Immediate action needed there. So how do we confirm it's bronchiectasis?
When we suspect it, usually because of that chronic productive cough we mentioned, the gold standard for diagnosis is a high-resolution CT scan.
That gives the detailed picture.
Exactly. It shows the bronchial dilation clearly.
Yeah.
A chest X-ray might show some nonspecific things, but the CT is key. Spirometry often reveals an obstructive pattern, too.
Cleaning.
Meaning a decrease in the FEV1, that's the forced expiratory volume in 1 second, and the FEV1-FVC ratio. Sputum cultures are also vital.
To know what bug you're dealing with.
Precisely. Identifying bacteria like Haemophilus influenza or Pseudomonas aeruginosa helps tailor the antibiotic treatment.
Right. Since there's no cure, the focus is management. How does the interprofessional team approach this?
It centers on managing those acute flare-ups, the exacerbations, and trying to slow the decline. Antibiotics are the mainstay, often for prolonged periods, sometimes even inhaled, and they're tailored to those sputum culture results.
And other meds.
Bronchodilators and corticosteroids can help manage bronchospasm and inflammation. As nurses, your immediate assessment priorities in a patient who's distressed are absolutely ensuring a patent airway, making sure ventilation is adequate, and checking for stable vital signs.
And you're calling the provider if things look bad.
Especially for significant hemoptysis, yes. For stable patients, it's more about getting a thorough history and reviewing their current therapy.
What are the key nursing interventions we should focus on?
Two really stand out: airway clearance techniques, or ACTs. These are absolutely crucial for mobilizing that thick, sticky mucus. Think chest physiotherapy, postural drainage, things like that.
And the other one?
Hydration. Ensuring adequate fluid intake, usually 2 to 3 liters of low-sodium fluids daily. Unless there's a contraindication like heart failure, helps liquefy those secretions, making them easier to cough up.
And teaching the patient what to watch for.
Yes, patient education is huge. Teach them the red flags, increased work of breathing, changes in their sputum color or amount, or any amount of moderate to large hemoptysis. Even a small amount of blood needs reporting. Those streaks are common.
Okay. Clear priorities there. Let's move on to cystic fibrosis, or CF. You mentioned it's a cause of bronchiectasis in kids.
That's right. And CF is a really powerful example of how a single genetic defect can just, well, wreak havoc across multiple body systems.
It's inherited, right? Autosomal recessive.
Correct. It profoundly alters ion transport, leading to that abnormally thick mucus we talked about. It hits the lungs, the digestive system, especially the pancreas and biliary tract, and the reproductive organs.
But the prognosis has improved dramatically.
It really has. It's quite inspiring. Median survival has climbed from around 16 years back in 1970 to over 46 years today. That's thanks to early diagnosis and really significant advances in therapy.
So what's the core genetic issue?
At its heart, CF is about a defective protein. It's called the CF transmembrane conductance regulator, or CFTR protein, and it's caused by a mutation on chromosome 7.
And what does CFTR normally do?
Normally, it regulates the flow of sodium and chloride ions in and out of cells. Think of it like a gatekeeper for salt and water. In CF, these channels, these gates, are blocked or just don't work right.
Leading to thick secretions.
Exactly. Secretions that are low in water, abnormally thick, and sticky. Visualize this like clogged pipes throughout the body. These secretions plug up ducts in various organs, causing scarring and eventually organ failure.
Is that related to the sweat test?
Yes, precisely. A critical diagnostic clue is the high sodium and chloride concentration found in sweat. Because the CFTR protein isn't working properly in the sweat ducts, less salt gets reabsorbed back into the body, leaving more in the sweat.
Okay. How does this affect the respiratory system specifically?
Well, in the lungs, this thick, dehydrated mucus just overwhelms the cilia, those tiny hairs that normally sweep mucus and debris out.
So the escalator's broken again.
Pretty much. This obstructs the bronchioles, leading to chronic air trapping, hyperinflation, and this relentless cycle of persistent airway infection. Pseudomonas is a particularly common and troublesome bug here. Over time, this leads to lung tissue destruction and a drop in lung function.
And the GI system. You mentioned the pancreas.
Yes, pancreatic insufficiency is very common. Mucus plugs the pancreatic ducts, blocking the flow of digestive enzymes like lipase, amylase, and protease.
Which means trouble digesting food.
Big trouble, especially with fats and proteins. It also affects absorption of fat-soluble vitamins A, D, E, and K. So as a nurse, you'll see this manifest as steatorrhea.
Which is?
Oily, bulky, frequent stools. And often you'll see failure to grow or gain weight, especially in children. Another important consequence is CF-related diabetes, or CFRD, because the insulin-producing cells in the pancreas can also be damaged.
Wow, it really is multi-system. What are the typical clinical signs we'd see?
It's broad. In infants, about 20% are diagnosed because they have a meconium ileus, which is a bowel obstruction at birth. Other childhood signs are those chronic respiratory symptoms, wheezing, coughing, recurrent pneumonia, plus the failure to thrive, malnutrition, and steatorrhea.
And in adults?
Presentations can sometimes be more subtle. Maybe new onset diabetes or infertility might be the first clue, but that frequent, persistent cough-producing thick, purulent sputum is a hallmark across ages.
How is it diagnosed definitively?
The gold standard is the sweat chloride test. It involves stimulating a small area of skin to sweat, usually with a weak electrical current and a drug called pilocarpine, then collecting the sweat and measuring the chloride concentration.
What's the threshold?
A chloride level above 60 millimole is considered positive. It usually needs to be confirmed with a second test. Genetic testing is also crucial. often done as part of newborn screening, which is now mandatory in all 50 states. It confirms the specific CFTR mutations.
So managing CF sounds like a huge team effort.
Absolutely. It requires a dedicated interprofessional team, often found in specialized CF care centers. You've got nurses, physicians, respiratory and physical therapists, dietitians, social workers. Everyone plays a vital role.
What are the priorities for lung care?
The main goals are relieving that airway obstruction and controlling infection. This involves regular aerosol and nebulizer treatments, things like bronchodilators, bucolytics such as Dornase alpha or pulmozyme, and hypertonic saline to help thin the mucus.
And those airway clearance techniques again.
Critically important. ACTs like chest physiotherapy, CPT, with postural drainage, or using devices like a high-frequency chest wall oscillation vest are vital because the cilia just can't keep up. Patients usually do these multiple times a day.
What about infections?
Aggressive, prolonged antibiotic therapy is essential, often using 2 different antibiotics at once based on sputum cultures. Patients often need higher or more frequent doses due to altered drug metabolism. Controlling chronic Pseudomonas infection is a major focus.
And the pancreatic issues.
For pancreatic insufficiency, patients take pancreatic enzyme replacement therapy, or PEAT, like pancrelipase with all meals and snacks. This helps them digest food and absorb nutrients properly.
So they need careful diet planning too.
Definitely. A high-calorie, high-fat diet is usually recommended, along with supplementation of those fat-soluble vitamins A, D, E, and K. Extra salt might be needed too, especially in hot weather or with exercise.
You mentioned CFTR modulators earlier.
Yes, this is a huge advancement. These drugs actually target the underlying defect in the CFTR protein itself. Specific drugs work for specific genetic mutations, so genetic testing is key to determine eligibility. They can significantly improve lung function and quality of life for many.
So as nurses, our role involves a lot of teaching and support.
Immense amounts. Reinforcing proper ACT techniques, medication adherence, which is complex nutritional strategies, monitoring for complications like CFRD or DIOS, distal intestinal obstruction syndrome, and providing ongoing psychosocial support. It's a chronic, demanding disease to live with.
Okay, let's shift gears to asthma. This one is really common, affects millions, and can be quite unpredictable.
Very unpredictable. It's defined as bronchial hyperreactivity with reversible expiratory airflow limitation. That reversibility is a key difference from COPD, but it can range from very mild, maybe just occasional symptoms, to severe and life-threatening.
And triggers are a big deal in asthma.
Absolutely paramount. Identifying and avoiding personal triggers is cornerstone of asthma management. These can be patient-related, like a genetic tendency towards allergies, we call that atopy, or environmental.
What are some common environmental triggers?
Oh, lots. Allergens like dust mites, pet dander, cockroaches, pollen, molds, irritants like cigarette smoke, both active smoking and secondhand air pollution, strong odors.
What about infections?
Respiratory tract infections, especially common colds, are major triggers. They increase airway inflammation and hyperresponsiveness. Exercise can also be a trigger, particularly in cold, dry air. That's exercise-induced bronchoconstriction, or EIB.
And medication.
Yes, definitely need to ask about those. There's the classic asthma triad, nasal polyps, asthma, and sensitivity to aspirin or NSAIDs. Beta blockers, even eye drops like timolol, can cause bronchospasm. Patients need education on reading labels.
It really is a labyrinth of potential triggers. So what's happening underneath all this? The pathophysiology.
Okay, so the core issue in asthma is persistent but variable inflammation of the airways. When someone with asthma encounters their trigger, it sets off an inflammatory cascade.
Like a chain reaction.
Exactly. Mast cells, which hang out just under the airway lining, get activated and release a whole bunch of inflammatory mediators. Histamine, leukotrienes, cytokines.
And what do those mediators do?
They cause a few things rapidly. Vasodilation, which leads to airway edema or swelling, increased mucus production, and critically, contraction of the smooth muscles surrounding the airways, that's bronchospasm or bronchoconstriction. All this narrows the airways.
That's the immediate reaction.
Yes, that's the early phase response happening within minutes. But for about half of patients, there's also a late phase response.
What's that?
This kicks in about 4 to 6 hours later. More inflammatory cells are recruited to the airways, and the inflammation and bronchoconstriction can continue for 24 hours or even longer. Corticosteroids are particularly effective at targeting this late phase response.
And over time, this causes permanent changes.
It can, yes. Chronic ongoing inflammation can lead to structural changes in the airway wall. We call this remodeling. Things like fibrosis, thickening of the smooth muscle, increased mucus glands. This can lead to a progressive and sometimes irreversible loss of lung function.
So what are the classic symptoms of an asthma attack?
The characteristic symptoms are wheezing, cough, dyspnea or shortness of breath, and chest tightness, usually occurring after exposure to a trigger.
You mentioned wheezing. Is that always present?
Usually, yes, especially on exhalation initially, but it's an unreliable sign of severity. You can have minor obstruction with loud wheezing, or, and this is critical, you can have severe life-threatening obstruction with no audible wheezing. This is the silent chest. Because airflow is so severely limited that there's not enough air moving to even create a wheeze. It's an ominous sign, a major safety alert for nurses. It signals impending acute respiratory failure. You need to call for help immediately. Ventilation might be required.
That's a crucial point. Silent chest equals emergency. How is asthma severity classified?
It's typically classified based on symptom frequency, nighttime awakenings, SEBA use, and lung function tests. Categories range from intermittent to mild, moderate, or severe persistent. This helps guide the stepwise approach to medication.
Stepping up or down therapy.
Exactly.
Mm-hmm.
Based on how well controlled the asthma is. The most severe complication is status asthmaticus,
Which is
a life-threatening emergency. It's a severe prolonged asthma attack that doesn't respond to the usual bronchodilator and corticosteroid treatments. It can rapidly progress to respiratory failure, requiring ICU admission, possibly intubation and mechanical ventilation.
okay. How do we diagnose asthma and monitor it?
Diagnosis relies on the pattern of symptoms, history, and objective measures. The peak expiratory flow rate, PEFR, is a key tool for monitoring. Patients use a simple handheld meter at home.
How does that work?
They take a deep breath in and blow out as hard and fast as possible into the meter. They track their personal best, PEFR, when they're feeling well. Then, they use a zone system based on percentages of their personal best.
Green, yellow, red.
Right. Green zone, 80–100% of personal best, means good control, continue usual meds. Yellow zone, 50–80%, is a caution sign time. Use reliever meds, follow the action plan, maybe contact the provider. Red zone, below 50%, is a medical alert. Use reliever meds immediately and seek urgent care.
And spirometry.
Spirometry is crucial for diagnosis. It will show that obstructive pattern during an attack, low FEV1, low FEV1-FVC ratio. Critically, it also shows reversibility. If the FEV1 improves significantly, typically by more than 200 millivalt and 12% after inhaling a SEBA, that confirms the diagnosis of asthma.
Okay, let's talk treatment. What's the goal?
The overall goal is to achieve and maintain control of the asthma, meaning minimal symptoms, normal activity levels, infrequent exacerbations.
And medications are key.
Yes. There are two main types. Reliever meds for quick relief of acute symptoms, and controller meds taken daily for long-term management.
What are the main controller meds?
Inhaled corticosteroids, ICS, are the absolute first-line controller therapy for persistent asthma. They're powerful anti-inflammatories that reduce airway hyperresponsiveness and prevent exacerbations.
What about side effects like thrush?
Good point. Oropharyngeal candidiasis or thrush and hoarseness can occur. Using a spacer device with the MDI and rinsing the mouth with water after each use significantly reduces these risks.
And the relievers?
The main relievers are the short-acting beta-2 agonists, SEBAs, like albuterol. These are the rescue inhalers. They work quickly within minutes to relax airway smooth muscle and relieve bronchospasm.
Can patients rely just on SEBAs?
No. If a patient needs their SABA frequently, it's a sign their asthma isn't well controlled, and they likely need controller therapy, usually an ICS. Over-reliance on SABAs is linked to poorer outcomes.
Are there long-acting bronchodilators too?
Yes, long-acting beta-2 agonists, SABAs, like salmeterol or formoterol. They provide bronchodilation for about 12 hours. But, and this is critical for asthma, LABAs should always be used in combination with an ICS, never as monotherapy.
Why not?
Because while they help with symptoms, they don't address the underlying inflammation. Using them alone can mask worsening inflammation and has been linked to increased risk of severe exacerbations and even death. Combination ICS-LABA inhalers are very common and improve adherence.
Makes sense. You mentioned spacers for MDIs. What about other inhaler types?
Technique is vital. Meter dose inhalers, MDIs, require coordination pressing the canister while inhaling slowly and deeply. Spacers make this much easier and improve drug delivery to the lungs. Dry powder inhalers, DPIs, are different. They're breath activated.
Easier to use?
Often, yes. No coordination needed. The patient just needs to inhale forcefully enough to pull the powder out. However, not all drugs come in DPIs, and they might be difficult for someone with very low lung function during a severe attack. Nurses must teach and check inhaler technique regularly.
So in an acute attack, what's the focus?
In acute care, the focus is rapid symptom control. This usually involves oxygen therapy to keep SATs above 90–92%, repeated doses of SABAs, often via nebulizer initially, and systemic corticosteroids, oral or IV, to combat the inflammation, and watching closely for that silent chest or signs of fatigue.
Okay, finally, let's turn to chronic obstructive pulmonary disease, or COPD. It's progressive, often linked to smoking.
Yes, COPD is characterized by persistent airflow limitation that's usually progressive and associated with an enhanced chronic inflammatory response in the airways and the lungs, primarily due to cigarette smoke or other noxious particles or gases.
And it's different from asthma because the airflow limitation isn't fully reversible.
Exactly. While earlier definitions included chronic bronchitis, chronic cough and sputum, and emphysema, alveolar destruction, we now understand these are really features or phenotypes within the broader diagnosis of COPD. The defining feature is that persistent, largely irreversible airflow limitation.
And it's a major public health issue.
Huge. Third leading cause of death in the U.S., often underdiagnosed until it's fairly advanced.
What are the main risk factors? Is it just smoking?
Cigarette smoking is overwhelmingly the major risk factor. Around 80–90% of COPD deaths are linked to smoking. Anyone over 40 with a smoking history of 10 pack years or more should be considered for COPD if they have respiratory symptoms.
What does smoking actually do to the lungs?
It causes a whole cascade of damage: increased mucus production, damage to the cilia so they can't clear mucus, chronic inflammation, destruction of the tiny air sacs, alveoli. It leads to structural changes and remodeling. Secondhand smoke is also a significant risk factor.
Are there other risks besides smoking?
Yes. Occupational exposures to dusts, chemicals, and fumes over long periods can contribute. Air pollution plays a role. Recurrent severe respiratory infections in childhood might increase risk. And there's a specific genetic risk factor too, which is alpha-1 antitrypsin deficiency, AATD. It's an inherited condition where the body doesn't produce enough of a protein, AAT, that normally protects the lungs from damage by enzymes called proteases. Smoking drastically accelerates lung destruction in people with ATD.
Okay, let's get into the pathophysiology. What causes that persistent airflow limitation?
It's really a combination of factors driven by that chronic inflammation. First, you have inflammation and obstruction in the small airways, mucus hypersecretion, edema, fibrosis, bronchoconstriction. Second, you have destruction of the lung parenchyma, the actual lung tissue, including the walls of the alveoli.
That's the emphysema component.
Right. This loss of alveolar walls means less surface area for gas exchange, and critically, loss of the elastic recoil that normally helps keep small airways open during exhalation.
So the airways collapse.
They tend to collapse prematurely during exhalation. This leads to air trapping. Air gets in okay, but it's hard to get it all out. Lungs become hyperinflated over time.
Leading to the barrel chest.
Exactly. The chest wall changes shape due to chronic hyperinflation. The diaphragm also flattens and becomes less efficient. Breathing becomes hard work, especially exhaling. Patients feel progressively short of breath, particularly with activity.
And gas exchange suffers.
Definitely. As alveolar walls are destroyed and airways obstructed, you get a mismatch between ventilation, airflow, and perfusion, blood flow. This leads to hypoxemia, low blood oxygen, and as the disease worsens, hypercapnia, high blood carbon dioxide.
You also mentioned pulmonary hypertension earlier. How does that fit in?
That's a serious complication, usually in later stages. Chronic hypoxia causes the blood vessels in the lungs to constrict. Over time, the vessel walls thicken. This increased pressure in the pulmonary arteries is pulmonary hypertension.
And that affects the heart.
Yes. The right side of the heart has to work much harder to pump blood into these high-pressure pulmonary vessels. Eventually, the right ventricle hypertrophies, enlarges, and then fails. This is called cor pulmonale, or right-sided heart failure due to lung disease.
How is COPD classified or staged?
The GOLD-AD, Global Initiative for Chronic Obstructive Lung Disease, stages are based on spirometry, specifically the FEV1 value after a bronchodilator in someone with an FEV1-FVC ratio less than 70%. Stage 1 is mild, Stage 4 is very severe, but symptoms and exacerbation history are also crucial for guiding management.
What are the typical symptoms? Does it start suddenly?
No, it develops very slowly, insidiously. Often the first symptom is a chronic intermittent cough, maybe with some sputum production, that the person dismisses as just a smoker's cough.
Then the shortness of breath starts.
Yes. Dyspnea is the symptom that usually drives people to seek medical care. It's progressive, initially just with heavy exertion, then with everyday activities, and eventually in late stages, even at rest. Patients might describe chest heaviness, air hunger, or gasping.
What might you see on exam?
You'll often note a prolonged expiratory phase. It takes them longer to breathe out. Breath sounds might be diminished. Wheezes can be present. You might see that barrel chest shape, evidence of accessory muscle used for breathing, maybe the patient leaning forward in a tripod position. Pursed lip breathing is a common compensatory strategy.
And late-stage signs.
In lead stages, you might see signs of hypoxemia like cyanosis, bluish tinge to skin mucous membranes,
Uh,
or polycythemia, increased red blood cells as the body tries to compensate for low oxygen, which can give a reddish-blue complexion. Signs of cor pulmonale like peripheral edema or distended neck veins might appear.
how is COPD diagnosed and monitored?
History, physical exam, and symptoms are key, but spirometry is required to confirm the diagnosis. That post-bronchodilator FEV1-FVC ratio less than 70% is the defining feature. The FEV1 value helps determine the Goldie stage or severity.
What about imaging?
A chest x-ray often shows signs of hyperinflation, like a flattened diaphragm, but it's not diagnostic on its own. Arterial blood gases, ABGs, are important, especially during acute exacerbations, to assess oxygenation and check for CO2 retention, respiratory acidosis.
Let's talk management. What are the main goals?
Goals are to relieve symptoms, improve exercise tolerance and overall health status, prevent disease progression, prevent and treat exacerbations, and reduce mortality.
Is there any treatment that actually improves survival?
Yes, the only therapy proven to improve survival in hypoxemic COPD patients is long-term oxygen therapy. The goal is usually to maintain oxygen saturation consistently above 90% during rest, activity, and sleep, or a PO2 above 60 millimilches.
What about medications?
Drug therapy is mainly aimed at reducing symptoms and exacerbations.
Right.
Bronchodilators are central. This includes both short-acting, ZABAs, and long-acting agents, LEBAs, and long-acting muscarinic antagonists, or LAMAs, like tiotropium. Often, long-acting agents are preferred for maintenance.
Combination inhalers.
Yes, combination LABAMA inhalers are very effective. Unlike in asthma, LABAs can be used as monotherapy in COPD. Inhaled corticosteroids, ICS, are typically added, usually in combination with a LABA, for patients with frequent exacerbations or overlapping asthma features. But they aren't first-line monotherapy for most COPD patients.
What's the nurse's role in managing COPD? It
Uh,
sounds complex.
It is multifaceted. A huge part is smoking cessation. It is absolutely the single most important intervention to slow disease progression. Nurses play a key role in assessing readiness to quit and providing resources and support.
What else?
Preventing infections is crucial, so encouraging flu, COVID-19, and pneumococcal vaccinations. Teaching effective breathing techniques is important.
Like pursed lip breathing.
Yes, pursed lip breathing helps prevent airway collapse during exhalation and control dyspnea. You teach the patient to inhale slowly through the nose and exhale slowly through pursed lips, taking about twice as long to exhale as inhale. Effective coughing techniques also help clear mucus.
Nutrition seems important too.
Very. Many patients with COPD are underweight and lose muscle mass. Breathing takes a lot of energy, appetite can be poor. Encourage high protein, moderate fat diets, often small frequent meals. Resting for meals and using oxygen during meals if needed can help.
And pulmonary rehabilitation.
Pulmonary rehab is a cornerstone of management for symptomatic patients. It's a comprehensive program involving exercise training, education, smoking cessation support, and nutrition counseling. It significantly improves dyspnea, exercise capacity, and quality of life, even in severe disease.
It sounds like living with COPD involves major lifestyle adjustments.
Immense adjustments. There's a huge psychosocial impact. Patients often deal with anxiety, depression, social isolation, frustration. Nurses need to assess for these issues, provide support, teach coping strategies, and refer to mental health resources when needed.
And end-of-life care needs discussion.
Absolutely. COPD is progressive and life-limiting. It's crucial to have conversations about palliative care, hospice, and advanced directives, like living wills, proactively, so patients' wishes regarding care intensity, resuscitation, and ventilation can be known and honored.
Wow, that was a truly deep dive into obstructive pulmonary diseases. From the permanently dilated airways of bronchiectasis
Right, the structural damage there.
to the multi-system genetic complexities of cystic fibrosis,
A whole different mechanism.
the variable inflammatory triggers of asthma,
That hyperreactivity,
and the progressive destructive nature of COPD. We've covered a lot of crucial ground.
we definitely have.
What stands out to you as the most vital common thread among these conditions, and where do you see a nurse's assessment making the biggest, most immediate difference?
Well, to tie it all together, the common thread is undoubtedly that compromised airflow and the underlying cycle of inflammation, though the specifics differ greatly. But I think what truly makes the difference in nursing is understanding how each condition impacts a patient's daily life. their ability to function.
So the practical impact.
Exactly. Therefore, early and really astute assessment, focusing on those hallmark symptoms we discussed, the sputum and bronchiectasis, the reversibility in asthma, the progressive dyspnea and COPD, and prioritizing immediate interventions like airway clearance, oxygen therapy, or trigger avoidance education. That's paramount. Comprehensive patient education across the board is key.
Makes sense. Assessment, intervention, education.
Right. And thinking about the future, if we consider the increasing prevalence of these chronic conditions and the ongoing impact of environmental factors like air pollution and smoking, what do you think is the biggest challenge facing healthcare systems? How can we ensure truly equitable, high-quality care for all patients struggling with obstructive lung diseases in the coming decades?
That is a powerful question and a really important one for us all to consider. Thank you for joining us on this deep dive. Keep digging, keep learning, and definitely keep asking those critical questions. Until next time, stay curious.